This has been Stronach, and I will be speaking on the medial pivot bearing design in total knee arthroplasty. I have the following disclosures, none of which are relevant to today's talk. I would like to give special thanks to Dr. David Blaha and Dr. Lowry Barnes for providing images and slides for this presentation. The topics that we will discuss today are knee kinematics, total knee arthroplasty design to include traditional implants and medial pivot design implants. And then we will go more into depth about the medial pivot total knee arthroplasty to include survivorship, function, kinematics, and patient satisfaction. We first will look at knee kinematics. The knee has previously been described by the 4-bar link concept, and this concept states that the ACL and PCL coupling is what primarily drives knee motion as you go into flexion. This causes rollback of the native knee with the femur moving posteriorly in relation to the tibia, and in extension, the femur then moves once again back into an anterior position. In this 4-bar link concept, the ligaments drive knee stability and kinematics. When we look at the native knee anatomy, we find that the medial joint has a larger medial femoral condyle, a concave tibial plateau, and a medial meniscus that is well fixed and positionally stable, which minimizes translational mobility of the medial compartment. The lateral joint, however, has a smaller lateral femoral condyle, a convex tibial plateau, and a lateral meniscus that allows significant excursion and is much more mobile than the medial compartment. Native knee kinematics are based on the fact that there is asymmetry between the medial and lateral compartments, and the lateral femur rotates posteriorly around a center of rotation point found within the medial femoral condyle, and the knee does not actually roll back until you get into deep flexion at 115 degrees and beyond. Leading up to this, through the major arc of motion, the knee actually rotates around this medial pivot point with the lateral compartment moving posteriorly. Dr. Pinskerova and Freeman did a cadaveric study where they looked at passive motion with MRI at defined flexion angles. The knees were allowed to have freedom of movement to find their own path. The MRIs were then obtained and combined to provide a reproduction of motion. We are first going to look at an MRI of the medial compartment, and you'll see the green arc represents extension where the blue arc represents flexion. You can see there is minimal movement of the medial meniscus, and the majority of motion occurs around a central contact point between the femur and the tibia, with a single center of rotation appreciated in the medial femoral condyle. You can see that the knee slightly rolls anteriorly on the femur in extension, but then as you begin flexion, the femur will slightly roll posteriorly and engage on a central portion of the tibial plateau, where it will remain throughout the rest of the arc of motion. And you can diagrammatically see here that this occurs around a central point of rotation within the femoral condyle. Now, if we then take this and transpose this motion over a tibial plateau from an axial view, you can see that there is very little motion appreciated anterior to posterior within the medial compartment, with the femoral condyle staying very well centered on the plateau. We next will look at the lateral compartment MRI, and you will see a significant difference where there's posterior rotation appreciated of the femur in relation to the tibia, with significant motion appreciated of the lateral meniscus. Now, as we look at this diagrammatically, you can see that there is a significant posterior femoral translation, and the center of rotation point changes dramatically. Now, as we look at this from above, you see a significant difference between the medial and lateral compartments. As you start in a neutral position, you will see that the femur moves posteriorly in the lateral compartment, but stays well centered around a central point in the medial compartment. Now, as the knee then comes back into extension, you'll see this represented by the green lines. The knee will slightly slide anteriorly both in the medial and lateral compartments. The native knee is stable throughout the arc of motion, and primary stability for the majority of our activities come through the femorotibial articulation, as was just demonstrated. There is a lateral pivot point with walking, while there is a medial pivot point with flexion, as we just saw on these MRIs. Secondary stability comes from the ligaments and soft tissues. These function as check reins and prevent the knee from having instability at extremes of motion or force. This demonstrates that the knee does not, in fact, function as a four-bar link. Koo and co-workers conducted a study looking at the kinematics of walking, and this demonstrates that the knee has a lateral knee center of rotation. The image seen here shows a superior view down upon a tibial plateau, and the femur at toe off is in an anterior position and is externally rotated. As you go through the gait cycle, the femur at heel strike moves into a posterior and internally rotated position with the leg in full extension that is previously described as the screw home mechanism. And so when we look at this diagrammatically, the center of rotation is found to be in a position outside the knee laterally. The native knee with bending has a medial knee center of rotation, which is similar to what we saw on the MRIs. There is posterior translation with external rotation of the lateral femoral condyle and a relatively fixed position on the medial femoral condyle with only minimal posterior translation. Next, I would like to talk about total knee arthroplasty design. The traditional total knee arthroplasty design was based on the fact that increasing conformity leads to increasing constraint, and this was viewed as a bad thing. This would prevent the knee from rolling back and would cause kinematic conflict. This increasing conformity and thus increasing constraint would cause implants to come loose because they were not allowed to slide around and find their own path. And so the initial total knee arthroplasty designs made the bearings to be non-conforming. You can see this on the image to the right, where you have a cylindrical femoral component and a flat tibial polyethylene, and this functions like the sphere on a flat surface like you see below, where there was no constraint within the knee. We also typically will see symmetric tibial bearings. If you look in the top left, you can see a symmetric congruent bearing, which is not similar to our native anatomy, which is asymmetric. And so typically the symmetric bearings we see are within the cruciate retaining family, posterior stabilized knees, and congruent bearings. We'll frequently see femurs that have what is called a J-curve, which is non-spherical. This means that there's a different radius of curvature in different portions of the condyle, typically with a decreasing radius of curvature as you go deeper into flexion. Both condyles in these designs roll back simultaneously, and the implant design treats the knee like a hinge and does not reproduce the native kinematics of the knee. When we look at cruciate retaining total knee arthroplasty, this is a non-conforming bearing, and we have seen that rollback in fact does not occur, but instead leads to paradoxical motion, which has been described as a walking on ice sensation and can lead to mid-flexion instability, quadriceps avoidant gait, and the potential for risk of further instability with PCL rupture. If you look at the diagram to the right, red represents 0 degrees of flexion, where dark blue represents deep flexion. And what we see is that the femur actually slides forward in relation to the tibia with the cruciate retaining bearing. Now, this is demonstrated by the video here. If we pick this point on the femur, you can see that as the knee goes into flexion, the femur actually slides anteriorly in relation to the tibia. This is paradoxical motion that has previously been described, and the knee constraint is only provided by the extensor mechanism holding the femur in position. So the posterior stabilized total knee arthroplasty utilized a cam post mechanism to avoid this paradoxical motion where the cam will engage the post and prevent the knee from sliding anteriorly, and this then forces the knee into a mechanical rollback as the cam and the post are engaged. The problem with a posterior stabilized knee is that we see high contact force in a small area. This does not reproduce native kinematics. You can have patellar clunk from the box associated with the femoral design, and it requires additional bone removal from the femur. But posterior stabilized knee does allow the femur to translate posteriorly on the tibia as you go into deep flexion. Total knee arthroplasty is a successful surgery, but there remain 15 to 20% of patients that are not satisfied. This is a multifactorial problem and has been related to surgical technique, patient selection, soft tissue imbalance, midflexion instability, and abnormal kinematics. The last 3 issues can be related to implant design, and the leading cause for revision of total knee arthroplasty remains to be instability. Next, I would like to talk a little bit about the concept of the medial pivot design. There's a trend towards younger patients with increased activity expectations, and patients desire a more normal feeling knee. The traditional total knee arthroplasty substitutes knee stability and kinematics instead of attempting to reproduce stability and kinematics of the native knee. So there remains continued interest in improving the results of total knee arthroplasty and to provide a more natural knee through implant design. So the medial pivot concept seeks to reproduce native knee motion and allow stability to drive the kinematics, not the other way around of trying to exactly match the kinematics of the knee to drive stability. And so in the medial pivot design, it is similar to the native knee based on the fact that it has a spherical medial femoral condyle, and some designs have a spherical lateral femoral condyle as well, along with an asymmetric tibial insert. And the goal of this is to also minimize the need for soft tissue releases. This concept utilizes a medial ball-in-socket design. This is highly conforming and allows for a large contact surface area with a low contact stress, and this helps prevent edge loading. You can see in the image to the far right that there's asymmetry with a very deep dish appreciated in the medial polyethylene and a much shallower design laterally. So an example of this is the Zimmer Biomet persona, and this shows the medial congruent design contact area, and this is significantly greater at 0 and 45 degrees of flexion in comparison to their ultra congruent line of the persona and of the natural knee. So the other design feature is the lateral arcuate trough of the medial pivot knee. There's less conformity than the medial side, and this allows for anterior-posterior translation. The curvature of this arc follows the medial center of rotation, and it allows for the lateral contact point to move posterior in deep flexion. So the first generation medial pivot knee was the FS1000 and was so named because it was designed by Michael Freeman and Kent Samuelson. It had a spherical medial condyle and a cylindrical lateral condyle, but was only offered in limited sizing. And the goal of this medial pivot design was to provide a ball and socket type implant for the knee that reproduces the ball-in-socket of the hip joint. We now have many different offerings available to include the MicroPort knee, which was previously owned by Wright Medical and includes the Advance and Evolution designs. Medacta has the GMK Sphere. Matt Ortho had the MRK and also now has the Safe knee. And both Zimmer Biomet and Smith & Nephew have polyethylenes for medial congruency. There are multiple variations when we look at the different implant designs. If you see above, there's the Matt Ortho Safe knee. This has asymmetry appreciated between the medial and lateral condyles. Implants can have either a single or dual spherical condyles, and this specific implant has a deepened lateralized trochlear groove, and there's variation between implants on the trochlear groove position. The tibial design typically is going to have an asymmetric base plate, as seen here, which is going to be larger anterior to posterior medially than it is laterally. This is also true of the asymmetric polyinsert that we just saw, that is going to be constrained medially and typically allow for freedom of motion laterally. This shows the MicroPort Advance, where there are multiple tibial polyethylene designs with different manufacturers. The top shows a cruciate substituting insert, which is the medial ball-in-socket concept. You utilize a cruciate retaining femur and you sacrifice the PCL, and you allow the congruency of the insert to substitute for the PCL. The middle image shows the cruciate retaining insert, which is ligament sparing, and there's a posterior recess that avoids PCL impingement. The third design shows the posterior stabilized insert, which has a cam post mechanism and an anterior lip that supports the femur until the cam engages. This design has a late cam engagement compared to traditional total knee arthroplasty, and it does not engage until 80 degrees of flexion. And so as you can see between these designs, there's variation in the femoral rotation and the positional patterns based on range of motion. So why does all this matter? There are several different designs with these different manufacturers, and not all implants are created equally. There is design variation, which may potentially lead to differing kinematics, and we would anticipate a variation in outcomes and survivorship based on these differences in designs. So it is important for you to know your implant design rationale and what are the goals of the bone resections and alignment, along with soft tissue balancing and potential releases that will be required to get the knee stable. So next I would like to look at some results, and we will start with survivorship of the medial pivot total knee arthroplasty. So the first study was a fairly comprehensive meta-analysis that looks at 5 registries and also looked at 25 studies to include 3,684 cases. And they found survivorship of the medial pivot total knee arthroplasty free of loosening at 99% at 7 years from the studies listed. They also looked at registry data, with the most patients being present in the National Joint Registry seen on the far left with over 26,000 patients, and the Australian Registry with over 18,000 patients. The majority of knee replacements were the MicroPort Advance knee, and we see that the revision rate was 5% at 15 years in the National Joint Registry and was up to 8.1% in the Australian Registry. The other implant designs across the registries either do not have sufficient numbers or sufficient follow-up to make any clear deductions about the survivorship of these designs. The authors found, based on this registry data, that there is comparable survivorship compared to traditional total knee designs when you look at the medial pivot design knee. Now, another study that looked at registry data was done looking at the Norwegian and Australian registries from 2005 to 2017, and they looked at 5 medial pivot total knee arthroplasty designs versus 3 of the most common traditional total knee arthroplasties. They only included patients in the study that did not have resurfaced patellas. When we look at this data a little bit more closely, we see that the Norwegian registry only had 1% of their total knee arthroplasties as medial pivot knees, which only gave 298 patients in the study. Because of these low numbers, they found no difference in revision risk, even though the hazard ratio was slightly higher at 1.5. It did not reach statistical significance. Of interest, they found the cause for revision to be loosening at 28% and instability at 28%. These both could be attributed to implant design. When we look at the Australian registry, 9% of all total knee arthroplasties were medial pivot to include over 6,000 knees, and they did find an increased revision risk in the medial pivot design with a hazard ratio of 1.4, but this was implant dependent. There were two designs that specifically were found to have inferior results compared to traditional total knee arthroplasties, but the other three designs had similar results to the traditional knees. It is interesting to note that the primary cause for revision in the Australian study for medial pivot knees was infection, which is something that we typically would not contribute to implant design. The loosening revision rate was only 12%, which is significantly different from the findings from the Norwegian registry. Another study looked specifically at the advanced medial pivot knee from one center. They looked at 284 knees, and they found a 97.3% survivorship at 15 years. They also found improvement in the Knee Society, WOMAC, SF12, and Oxford knee scores. A similar study looked at 347 knees, which was the MicroPort Advanced design, and they found a 98.8% survivorship at 17 years, with similar improvement in Knee Society, WOMAC, SF12, and Oxford knee scores. When we look at survivorship, it appears that the medial pivot design has a similar survivorship to traditional total knee arthroplasty, but there does appear to be variation in results based on design. The Norwegian data raises some concern for increased risk of revision due to loosening and osteolysis, but there was a very small number of patients in this registry, and longer-term follow-up and a larger cohort is needed to gain further information about survivorship comparisons between the medial pivot total knee arthroplasty and traditional total knee arthroplasty designs. Next, I would like to look at the literature on function. This is a study by Hossein and coworkers that looked at 76 medial pivot total knee arthroplasties, which was the MicroPort Evolution, in comparison to 88 posterior stabilized total knee arthroplasties, which was the Zimmer Persona. They found no difference in the preoperative to postoperative change in range of motion between the two groups, but they did find a higher forgotten knee score in the medial pivot total knee arthroplasty design of 59.7 compared to 44.8 at a p-value of 0.007 at a minimum of 1 year follow-up. When we look at function, there are currently only limited studies to date, but we see that the medial pivot knee is non-inferior and potentially superior in function in comparison to traditional total knee arthroplasty. Early results indicate that the medial pivot knee provides anticipated benefit as expected. Next, I'd like to look at studies that review the kinematics of the medial pivot total knee arthroplasty. This first study by Dr. Scott looked at 16 of the Medacta GMK sphere knees, and they utilized pulse fluoroscopy and weight-bearing and non-weight-bearing, along with static and dynamic assessment. And they found a fixed medial point of rotation with motion, which we would expect, with lateral excursion of the femur in relation to the tibia. And they found that the medial pivot knee design functions as intended and is similar to the native knee. If you look at the images on the right, the top image in the light tan color shows lunging, and we can see that there is significant posterior excursion of the femur in relation to the tibia in deep lunging, and a similar finding with kneeling. As we go to the middle image, as the patients stepped up and stepped down, we see that the lateral portion of the knee would rotate posteriorly into flexion about a fixed medial point with slight anterior rotation of the femur as the knee pivoted. So Shimon and coworkers performed a similar study on 14 Mat Ortho safe total knee arthroplasties. This also used fluoroscopy, and they used the same activities as in Dr. Scott's study. They found an average maximum flexion of 127 degrees with a range of 100 degrees to 155 degrees. They also found asymmetric posterior translation of the lateral femur in flexion as we would expect, and they also found there was no paradoxical motion appreciated of the femur on the tibia. So in conclusion, when we look at kinematics of medial pivot design, the implants are behaving as designed. It is still unknown if this equals functional improvement. So next, I would like to look at patient satisfaction. In this study by Batra and coworkers, they performed 53 bilateral total knee arthroplasties. One side received a medial pivot total knee arthroplasty with a microport advance, and the other side received a posterior stabilized total knee arthroplasty with a Smith & Nephew Genesis 2. They then had a minimum of 4-year follow-up, and they found that the knee society scores were higher in the medial pivot group in comparison to the posterior stabilized group, and in vivo kinematics of the medial pivot knee were better than the posterior stabilized knee. Another study by Lin and coworkers looked at 121 patients that received a medial pivot knee with the microport advance and 332 knees that received posterior stabilized implants. 219 of these patients received a Zimmer next-gen knee, and 113 received a Stryker Scorpio knee. They found similar satisfaction at 87% for the medial pivot, 90% for the next-gen, and 90% for the Scorpio. And they found no difference in overall pain or range of motion. They also found no difference in satisfaction or function between the medial pivot design and the traditional total knee arthroplasty. So in conclusion, for satisfaction, there are conflicting results. All are comparing different implants. So none of these studies compare the same manufacturer and the same implants with different polyethylene designs, but they are in fact comparing different bearings, such as medial pivot to posterior stabilized, amongst different manufacturers. And this introduces significant potential for variation in the results based on the overall implant design. The Batra study is interesting because they performed bilateral total knee arthroplasties in the same patient with different knee designs, which helps decrease any cause of patient variability. So in summary, the medial pivot total knee arthroplasty design reproduces the normal knee kinematics. Registry data to date demonstrates non-inferiority. There is variation in survivability based on the design, and the AP stability through conformity potentially confers functional advantage as demonstrated by multiple studies. We currently do not have enough data about the medial pivot knee in regards to kinematics, function, and survivability to draw any definitive conclusions. I want to thank you for your time and for the opportunity to speak, and I look forward to answering your questions. Thank you.